and they as decorations around their legs. So probably that helps them to maintain their bones. I think what helps them also is going to the village well and collecting a lot of water, walking back with heavy water on their head, pots of water on their head, which helps their bones probably.
Can I just explain that the term weight bearing doesn't necessarily mean you have to carry any weight. Just your own body weight is enough, as long as it's exercise against resistance. So just normal walking, you don't have to carry anything, is already a very good thing.
Yes.
But I think the most important thing with exercise is that it is not intuitive for somebody who's just been told that you are at risk of fracture to now tell them to go exercise, because they're afraid that they're going to increase the risk of fracture by exercising. So one has to get around that message that they actually do need exercise, even though they are at risk of fracture. And as mentioned before, it also helps in muscle coordination, etc., to prevent falls.
Yes. Since you brought up the issue of muscle coordination, I mean, when women have frailty fractures, such as when they are very old, they have difficulty in balancing, and they have a higher chance of fracture. Is there any kind of fracture which occurs with, does the hip fracture occur mainly because of that? Because of not being able to balance whilst walking?
Yeah, I would certainly say that that is a large proportion. It is very seldom that a hip will just fracture all spontaneously by itself. There's always been this debate about did she fall because she fractured, or did she fracture because she fell. And I believe that the studies on the hip protectors have conclusively shown to us that the patient will first fall and then fracture. Because if they wear hip protectors and they fall, they don't fracture.
Okay. And we have patients who have osteoarthritis and they have osteoporosis. Is there any connection between the two?
Usually not.
Are you asking me?
Anyone can answer. You can answer too, Toby.
Okay, it's a very, very strong correlation between rheumatoid arthritis and osteoporosis. As such, it is one of the most sensitive indicators in the FRAC study. Between osteoarthritis and osteoporosis, there's also an overlap, but a much lesser overlap. And it's really two different conditions, but it's very often confused by patients. So patients will come with a diagnosis of OA and osteoarthritis and then come to a doctor with osteoporosis. But the other interesting thing is that many of the drugs that we use actually overlap in their effect on both. So most of the anti-fracture drugs that we have today will also have a small spillover effect on improving osteoarthritis, although it's very seldom used primarily for that reason.
Okay. So then we go on to the next question which we have is the last one on the risk factors for osteoporosis is the medications which we may be taking and which may be causing problems with our bones. So the common ones, if you can add on Usha, what are the ones which are giving us osteoporosis?
So the number one culprit is, we all know, is the steroids. Anyone who's been taking steroids for a long time or a higher dose, we know that it predisposes them to bone loss and osteoporosis. And therefore, I think that is one condition where proactively we have to treat the patient. Then thyroxine, either higher than normal requirement of thyroxine that someone is taking, or someone who has hyperthyroidism, especially postmenopausal women, are at high risk for bone loss. And there are actually a long list of medications that can give rise to bone loss, and some of the anti-estrogen drugs, though we have drugs like tamoxifen and raloxifene which improve bone loss, and then we have other agents like anastrozole, and so we need to be cautious. We have to think of GnRH analogs. So these are all agents that can promote osteoporosis. But then I also want to mention things that we commonly use like PPIs, proton pump inhibitors, that we should be aware of, that what it can do to calcium absorption.
Yeah. So a
Because-
lot of us keep taking medications for hyperacidity. Someone's taking, most of us, I mean, whoever takes it usually are taking the PPIs today, and they are the ones commonly known to cause problems with calcium absorption and osteoporosis. So we have also sometimes women at an older age, as we are talking about midlife, people who are on antidepressants and people who are on tranquilizers, would they also have a higher chance of osteoporosis?
Like I said, there is actually a long list of medicines that can, worsen bone loss. The biggest culprits are steroids and thyroxine and these anti-estrogen hormones, but many drugs contribute some to either through vitamin D mechanisms or through excretion of calcium in the urine.
Okay.
Or
So a lot of drugs are causing problems with increasing the prevalence of osteoporosis at midlife. So now I think we have more or less covered most of the risk factors, and we move on to how do we diagnose osteoporosis. And Meeta, can I request you that yes, we do bone mineral density. We all know we do it by DEXA. And we know that DEXA is the standard of care for detecting bone density. But then if DEXA is not available, what other technology we can use, or how do we find out a woman has osteoporosis if in a place there is no DEXA available?
So I think at this point of time, Duru, I would like to, talk about the X-ray of the spine first, and then, move on to the risk that you're alluding to, because I think that has to be utilized more in a place like India, where we have these fractures occurring about 10 years earlier, around 40s and even, around 50s. So a simple X-ray of the spine would probably give you a lot of information on osteoporosis, which has been happening, albeit very late, though we may not be really diagnosing it earlier. But then in India, we should be looking at downstaging of the disease, and then comes the screening. So that is one thing that we need to do, the X-ray of the spine, thoracolumbar region, AP and lateral. And screening by clinical risk factors first is what we're supposed to do. Fraxes come into being, and India is using the Singapore and the one which we have in India, but we really don't know how effective it would be in terms of management of a patient, because we really don't have our own fracture data. So we still go ahead and use the old algorithms and the old risk factor assessment, clinical risk factor assessments, and then you decide which woman to treat or not to treat based on those clinical risk factors. But if you have a BMD, but you said you don't have a BMD, that's why I started off with an X-ray, because then clinical risk factors, your history taking, and your clinical examination would play a very important role. And then to convince, after diagnosis, to convince the patient to take a long-term therapy is really a big issue.
No, I understand, but there are a lot of people who use those ultrasound machines for the foot, and they give you a diagnosis of osteoporosis.
And we have had some experience with that. It has to be validated, and we have found a lot of, we ourselves have conducted quite a number of them, and we find a lot of false positives, and it is really frightening to find a 30-year-old having severe osteoporosis. And, so I think the reporting, and moreover, when it's done in that mass scale, many a times you really, what do you say, Usha? I'm not very comfortable with that.
I'm not comfortable also.
Yeah.
As far as X-ray, I do get an X-ray on all my patients once I diagnose osteoporosis to look for incident vertebral fractures. Because like you said, you really pick up only quite late. You need to lose about 30% of your bone for the bone to look osteoporotic. So to diagnose it, it may not be a very useful tool, but I recommend getting one in all patients once you diagnose osteoporosis, because that's the only way to pick up a fracture, a vertebral fracture. They may not come to us with that.
Yes.
But I was actually looking at it in a different angle,
Yeah,
Usha. In rural areas where we don't have the facility for
DEXA?
DEXA, and probably most of our women
You
are,
know, fracks.
no, but then if you
So,
don't have, fracks also
we'll
can be
discuss
used.
FRAX, the clinical findings. What I was looking at is that yes, we know DEXA is the standard of care, but how does ultrasound compare to DEXA? It's being used very commonly and for mass screening programs, but our personal experience has been that it doesn't have the same sensitivity. And the other technologies which have been used are MRI, quantitative CT scans, and X-rays. X-rays we have discussed, and there was one hospital where I remember they did not have a DEXA machine, and they were using a quantitative CT scanner for that. And do you all use it, Toby, at all? If you don't have a DEXA, do you use a CT scanner?
Could I, could I just first explain that DEXA is the gold standard for a very good reason. And the reason is that the values that we get have been validated. So if you go on the DEXA, you can refer to where it was validated, number one, and number two, it can be used for the follow-up of therapy, although not so easy, but it can be used. Now, none of the other methods have individually been validated, so although they try to follow the less than 1 standard deviation and the minus 2.5 standard deviations, that doesn't necessarily correlate to the same thing that the DEXA does. So that's what makes it very difficult, whatever other method you use. So ultrasound, I quite agree with the previous two speakers. We have tested it in screening programs for some of the drug trials, and in the individual, it just doesn't give you enough information. So the IOF's basis for screening is that you must have a high suspicion of index of the disease before you do screening. So if you have a high index of suspicion and you get a positive, a negative result on the ultrasound, you still have to do the DEXA because you haven't ruled out that she's got the disease. And on the other hand, if it's positive, you still have to do the DEXA to see if she qualifies for therapy, because the therapy has not been correlated with the DEXA. So I just find it's a very expensive way of getting to the real answer. In terms of the MRI and the CT scanner, that is only used for research purposes. And there are certain advantages to doing the MRIs or the specific CT scanners, which will give you a better idea of exactly what drugs does. So we use that in clinical drug trials to gain more information about the effect of the different drugs on bone. But I, again, for the same reason, do not advise it at all for the routine clinical management. One should also realize that the cost of an MRI or CT scanner is about, or the per examination, is probably about 5 to 6 times the cost of a DEXA scanner. I hope that answers you.
Yeah, absolutely, Toby. So when we go to the bone density, which quite a few of us in Mumbai are using, there is a kind of a report which comes in, and could you tell us, Toby, how you would read this report? It gives you an actual answer, not that it doesn't. Like whether the bones are normal at a particular level in the forearm, in the lumbar region, in the hip region. But the question is, would we be able to assess the amount of risk of fracture only looking at a BMD report? When they give you the T-score and the Z-score, can you base on that the risk of fracture?
Okay, this is where I have a good look at this report here. Basically, I first need the age of the patient to see whether one should actually use the T or the Z-score, because Z-score should be used in premenopausal patients. And the range for Z-score is much wider, and normally it's from -1, is up to -2, where it's different with the T-score, which is for postmenopausal women. Now, in this specific one that we have here, I see that the left forearm was done as well as the spine and the right femur. Now, in anything I say about a DEXA report, I would like to refer to the rules of the ISCD, because I believe that that is the standards that everybody should follow in reporting on DEXAs. And you can get it on the iscd.org on the net, and it clearly defines how you should read a DEXA. Now, one of the rules that they have is that you never do the forearm if you have an adequate reading at either L1 to L4 or one of the two hips. So in this particular case, I would discard the forearm. You only use it if you haven't got, say for instance, the patient has that bilateral hip replacements. You can't do that, then you add that. And you always report on the lowest of the two that you use. Now in this particular case here, it seems like the value is, but if this is a menopausal patient, this is correct in that it should be reported as normal. And in the absence of any fractures, this patient has not got osteoporosis. But in the presence of any fracture, or whether it be, preferably a fragility fracture, which means a fracture when falling from our own body height, this actually falls away and the patient should be regarded as osteoporotic. So what you need with this one is you need an age added to this, and you need some comment about whether the patient's got any fractures or not.
What was the last sentence you said, Toby? Whether the?
Any fractures.
Okay, fine. History of
Whether
fractures.
there's
Okay.
any fractures.
Okay, so looking at a DEXA report, only looking at T-score or Z-score is just not enough for us to assess what will be the fracture risk. Because as we mentioned earlier, fracture depends on the bone strength, the bone quality, and basically the turnover of the bone. So besides DEXA, there are some bone biomarkers available, both in the serum and in the urine. There are a whole lot of biomarkers available. Usha, do you use any of these in diagnosis or do you use them for prognosis?
No, only to guide therapy, and that too quite infrequently.
Yeah.
Yeah.
So you don't use most of them?
Not for diagnosis.
No.
So
Yeah.
for guiding therapy also, if I'm using anabolic therapy, the P1NP, we follow that. But in terms of when we use anti-resorptives, only in very special situations where I want to either talk to a patient about a particular therapy or some form of monitoring compliance, or everything is fine but the patient has had a fracture, so I want to know what's their status of the bone turnover. So very special situations, but not routinely.
Yeah, but which is the biomarker you prefer to use? These are the serum ones and these are the urinary
Yeah,
ones.
I would use, like I said, if I'm using anabolics, I'm using like P1NP, but if we are using anti-resorptives, we might use the NTX or CTX.
So, anyone?
Can I
Yes,
chip in
Toby.
there?
Yes, please, Toby.
Yeah, I do not disagree with the previous speaker at all, but I think for the purpose of your audience today, which I believe are mostly generalists, I don't think that there's any indication in routine clinical work to use the bone markers. The bone markers are basically for specialist bone people and for researchers. It tells us a lot about what's going on at bone and how different drugs work, but for clinical monitoring in routine practice, it has very little place. For the following reasons: one, there's a lot of noise in the assays, even in the same patient that's not repeatable all the time. Secondly, there are some very strict criteria in how you should do it, the time of the day, the temperature control, etc., and the transport to the lab. Otherwise, it just really doesn't mean anything. So I would say for the purposes of your audience today, they can really forget about bone markers. It's not going to help them at all. This is really
yeah.
for the true specialists and not the generalists.
Thank you so much, Toby. Would you like to add something, Meeta?
No, I think what Toby said is absolutely correct, that it should not be used for routine practice, and rightly because she's been an endocrinologist and maybe those special situations, and we have using it only for research purposes when we conduct studies, and rightly said, the
Even I use it
yeah,
extremely rarely.
Yes.
I mean,
he has put it
very
so well, we don't need really to add
Yes,
anything
okay,
now.
fine. Thank you, Toby. So we'll go to the next part of our discussion is one is how do you assess the risk of fracture? So there's something called the WHO FRAX calculator tool, which is based on clinical risk factors plus some inputs from these investigations. So would you like to run through it, Meeta?
I think it would be a good idea because this is something which people can adapt
Correct.
without having the bone mineral density. So so you really we have offline on paper frax charts which people can use, and if somebody is using or online also you can use both of them. But I think yes, we should start with the age. So you have about 12 variables in this. 10 or 12, 10 variables, and then you enter all of them, like the age of the person in years. You want me to go through each one of
No,
them?
basically you take factors like the age, the weight, the whether there's been any fracture before. These are the important
You need to
terminologies.
enter it exactly the way
Yes.
it asks you to.
Yes.
So then it generates a figure after that.
Yes.
So then you get the chance of a fracture over the next 10 years.
Just wanted to say the good news here is till now we were using Singapore Indian data, but very recently our own Indian data has been put in.
Yeah, but that is where, the our guidelines differ a little bit from there because the interventional thresholds that emerge is not really very accurate because the fracture data that has been put in was for a very small number of patients, just about 400. So that didn't really generate the kind of work that we were looking for. So,
I'm just
but
saying
then for practical
For
purposes.
practical purposes, we have our own
Yeah,
Indian data.
true.
Dr. Sanjay Badada has contributed to that.
Yes,
So
yes.
that has been put in. And so the FRAX tool is for when you don't have a DEXA. And by the way, the FRAX can also be used with you can also add DEXA data and get, even more information.
Correct. See, once, I think that would be her next question, Dhruv.
It's not-
How do you interpret it?
No, we don't have the interpretation here. I thought I was getting it from you.
So would you want me to answer that
Yes,
question?
please. Sure.
Yes.
Yeah.
So actually the whole idea of doing this, see, once you have a diagnosis of osteoporosis and a fragility fracture, there are no two ways you are going to treat them. So the problem arises only when you're not sure and when they are in the osteopenic range. So how do you know whether they're in the osteopenic range, and what are you going to do when you suspect a low bone mass? And that is what this FRAX is all about. So you generate that whether she is at a high risk of fracture by generating some numbers. So according to the FRAX, according to the UK, and every country has their own interventional percentage thresholds. So it's either 20% for major fractures and 3% for hip fractures. So that is the kind of data that we need to generate in India before we can say that 20% mark or 3% mark is okay with our economics, our cost effectiveness, and the mortality rates for the fracture. So that is where there is a little bit of confusion, but still, nevertheless, I think FRAX without BMD and FRAX with BMD, if we can adopt, it would go a long way.
So basically, it's an assessment tool. This is because we are dealing with a global audience today. It's not only India, we are all over the world. And as a matter of fact, FRAX tool is a very good calculator for assessing clinically what is the risk of fracture. If you go on to these osteoporosis websites, or the WHO website, you can download the form and it will give you all the details. But basically the clinical details are where you are, as Toby mentioned earlier, rheumatoid arthritis is one of the factors which is there. Then there's glucocorticoids, there's being a current smoker, whether there's history of fracture in the parents, whether there's history of fracture in the individual himself or herself, depending on how much you're drinking, 3 drinks a day. So these are the various factors or the clinical risk factors. And then if you have a BMD, you tie it up with the BMD. If you have a BMI, you tie it up with the BMI, and then you can assess. There is a way of calculating the risk. So for every country, as it was mentioned, there is a different module. I mean, there is interpretation, but in short, what we are saying is this is something which you can start using in your own offices and try and assess the risk of fracture amongst the women who come to you. So when coming back
Dhruv,
to...
can I just add something
Yeah.
over here when you're talking about clinical risk factors? And I would like to take the opinion of Dr. Toby on this. In India, we have osteomalacia is very much prevalent. And so, that doesn't figure into the risk factors, which all of us should probably look into: vitamin D deficiency, calcium deficiency, low protein intake, and high salt intake. That is the scenario. So, which is more closely associated with osteoporosis, that is one. And diabetes type 2 is very much prevalent. So these kind of issues, which are country specific, do you think these things need to be taken into consideration before we decide to treat osteopenia? Toby, I would like to take your opinion on that.
Okay, just to get you the particular conditions that you have mentioned, if you go back to the FRAX model and you have a look under secondary causes, most of the things that you mentioned are in fact included under secondary causes. So if you have a patient with osteomalacia or vitamin D deficiency, then you have to tick the box that says secondary causes. So there is actually provision for that. But I just like to put the FRAX into clinical perspective. Where do we use the FRAX? Just make it easier for your normal clinicians. And I would, as a general statement, say that if you have a bone density report, like the previous one which you showed me, that was absolutely normal, you would rarely ever need to treat such a patient. On the other hand, if you have a bone density report that says that either the level of the spine or the hip, you have a value equal to or less than minus 2.5, you should probably treat that patient irrespective of risk factors. As in the clinical trials, those are the patients that were included and those are the patients that improved. So your problem is the so-called osteopenic patient. That's the one between t-score of -1 and -2.5. Because the reality is, again, the absolute relative risk versus absolute risk. So although the absolute risk of fracture is higher in the -2.5s, the absolute risk is higher in the osteopenic patients, just because there are so many more patients with osteopenia than osteoporosis. We actually have more fractures in that group of between -1 and -2.5. So in order to get around that and to know which patient you need to treat with osteopenia, that's where you add the risk factors. Now, if you have access to internet and the FRAX model, it's a very, very neat way of doing it. And we have referred to, but when do you add to the FRAX model? Your local society should say which is country specific, but as a general rule, you can use the American figures, which suggests that if you have a 5-year risk of hip fracture exceeding 5%, you should probably treat. Or if it is a 20% risk or more of any major osteoporotic fracture, because those are the two ways in which FRAX reports, then you should also treat. Another way of doing it, if you haven't got the instant internet access, is if you have more than 2 or maybe even 3 of these risk factors as known with osteopenia, you should also strongly consider to treat. So that's just where this fits into the clinical picture. It is more for the patient in the osteopenia group, as the patient who's already osteoporotic on the DEXA report should most likely be treated, because we've got the evidence that they need it and it works.
Very good, Toby. That was a very excellent explanation. Now there's one last question on this. If I have a 50-year-old woman who's just reached menopause and walks into my office, should I routinely offer her a DEXA scan? Should I ask her to get a DEXA scan done?
Do you want?
No.
If a woman...
Well, I think if we... are you asking me the question?
Yes, Toby. Yes, please
I
answer.
don't mind if anyone else answers
No,
it.
I'm going to ask everyone this
Okay,
question.
I will answer it from the perspective of the International Osteoporosis Foundation. The International Osteoporosis Foundation strongly advises against any routine DEXA that is done before the age of 65. And they advocate a case-specific approach. So they reckon that if you have risk factors present, but you are uncertain as to whether you should treat or not, then you can do a DEXA estimation. Now what happens in the real world, that it is probably determined by the excess and the cost of a DEXA examination. Because you can argue that just the fact that she is menopausal or turned menopausal is a risk factor, and very often you would get low BMI or something else with that. So there will be patients that will qualify according to the IOF's qualification, but I would just end this by saying that there is no strong case to routinely do DEXA on all menopausal patients. It just is not cost effective.
Okay, what about you, Usha?
So I don't routinely screen all immediately after menopause, but I think spating till 65 for Indian women is probably too late, partly because our menopause is a little bit earlier, closer to 47, in that age group. And also